Thank you very much, Dr. Williams, for those kind words. Just take what he said with a grain of salt. He's just being kind. But thank you very much for the opportunity to participate in this important conversation, and thank you especially to Dr. Pratt and Dr. Williams for inviting me. I do have one disclosure that is not pertaining to the conversation today. 4, 5, 6, and 7. Here we go. I'd like to start with a reminder, two reminders actually. Number one, equity and equality are not the same. And equality is depicted there on the left-hand side, while equity is on the right. And equity is defined as every individual getting the resources that they need to thrive equally. In my mind, equity is the vehicle to equality, not the other way around. And our second reminder comes courtesy of Toni Morrison, who's one of the great authors in this past generation, who reminds us that race and racism especially are a social construct. They serve a social function. Now, that's not to say that there aren't genetic and biologic factors that are related to ancestry, and I'm going to touch on that a little bit later on. But what I think Ms. Morrison meant, and what I mean by this, is that sometimes we use race to capture, in aggregate form, the effects of more fundamental forces like social determinants of health, things like access to education, access to healthcare, economic and housing stability, neighborhood and built environment conditions. And those are truly the levers that are behind some of the disparities that we've documented, but also correlate and are captured by race. And so as we approach this topic of disparities, I think we need to keep that in mind. And with that, let's jump right on. So as previous speakers had mentioned, and this is no surprise, there's no arguing with the fact that childhood obesity is a national public health crisis. But that crisis has had a disparate effect on different races and also on individuals of different socioeconomic statuses. And if you think back to that initial picture that I showed you, this is sort of like the different heights of those three folks who were trying to watch the baseball game, right? They're starting off already at an uphill climb. So I think before we talk about treatment of obesity, it's important to talk about differences in the prevalence. Now, why do these differences exist? Well, we know that there are, the expression of certain obesity-related genes differs, and is it higher, in fact, in some individuals from African ancestry or Hispanic ancestry, and that may contribute to a higher prevalence of obesity amongst these populations. We also know that perinatal factors such as duration of breastfeeding, which has been inversely related to obesity, also is correlated with some subgroups. And we know that Black children, for example, are about 20% less likely than their white counterparts to be breastfed. And if you think back to social determinants of health, it's not difficult to imagine why that might be the case, why a Black or Hispanic mom who works multiple jobs and works at a job that is not amenable to pumping might have a difficulty with breastfeeding. We know that Black and Hispanic children are more likely to live in food deserts, areas with decreased availability of healthy foods and increased availability of foods that are high in transsaturated fats and sugars. We also know that even small things like sleep patterns, which are associated with obesity, also are related to these populations. And we know that Black children, in general, get fewer hours of sleep than their white counterparts. We know that Black and Hispanic children are more likely to live in areas of what's called double jeopardy, so areas with increased risk factors and decreased prevalence of protective factors. We know that they have higher rates of adverse childhood experiences. We know they live in areas of increased violence, areas which were historically redlined and now are concrete jungles, with higher rates of pollution, which leads to higher rates of asthma. And overall, all these factors come to compound and lead to the differences in prevalence that we observe, and then lead to these children and adolescents growing up to be adults with obesity and suffer from the associated medical problems and ultimately have an impact on their life expectancy, right? So it's important to keep that in mind. These three folks who want to watch the baseball game are starting at three different heights. Now, medical societies like the American Academy of Pediatrics have begun to recognize the importance and the superiority of surgery for the treatment of severe pediatric obesity, but they continue to recommend that a trial of lifestyle modifications and medical management is done before, whereas surgical societies like ASMBS are much clearer in their guidelines that bariatric surgery should be the treatment of choice for children with severe obesity, which is defined as class 3 or class 2 obesity with a associated medical problem. But before we jump to surgery, given that there's still recommendations for lifestyle and medical problems, I'd like to address that and how these folks have access to these treatment modalities. And unfortunately, at no surprise, if we think back to social determinants of health, we know that Black and brown children have a difficulty with accessing open spaces, safe play spaces, parks, a difficulty with comply with certain lifestyle modifications that hinder or that hinge very much on the parental socioeconomic conditions, right? So it's no surprise that they're less likely to succeed with this. We also know that anti-obesity medications are not cheap, and though some private insurances cover it, last I checked in 2020, only 7 states covered anti-obesity medications as part of their Medicaid program. And we know that Black and Hispanic kids are more likely to be covered by government-sponsored insurance. So again, they're starting off with a higher prevalence of obesity, and now they're experiencing barriers in the non-surgical treatment modalities. Well, what do we know about surgery? Well, we know that pediatric bariatric surgery is grossly underutilized. And in this study, we used NHANES to calculate the prevalence of severe obesity, which we define as class 3 or class 2 obesity with an associated illness, in 2015 and 2016. And we found that over 1.6 million children have severe obesity in the United States. And then using NIS and KID databases, we found that about 25% of those, or 2,500, underwent surgery, which equals a rate of surgical therapy of 0.15% among children who qualify for it. Now, that's abysmal, right? There's no other way to look at that. But unfortunately, even within that gross underutilization, there are disparities. And there's been studies to show that white adolescents are significantly more likely to undergo bariatric surgery than their Black and Hispanic counterparts. And that remains the case even when you account for insurance, because a lot of folks comment on these studies demonstrating race-based disparities, and they comment that maybe it's all related to access to care in the form of insurance. But even when you account for insurance, these disparities remain. In fact, in our study, we found that insurance actually had a differential impact on race when it comes to access to surgical therapy, in government-sponsored insurance being associated with an increased likelihood of utilization of bariatric surgery amongst white patients, while further decreasing the likelihood that they'll undergo bariatric surgery for Black and Hispanic children. Right, so it's a complex dynamic here, but in the end, what you end up is with children who started off at a different height. They started off shorter. They want to watch a baseball game, and now they're being given boxes that are shorter on top of that, right? So all of that just compounds to a gross disparity. So how do we move forward? We proposed a simple sort of framework to wrap our heads around this, that focuses on studying both the patient and parental factors, the provider factors, and the system factors. We think it's important to acknowledge that the different patient populations have different perspectives when it comes to body image. And it's been shown that racial minorities in the adult population actually have a higher quality of life when living with obesity. And it's important as providers to educate them on the fact that there are short and long-term deleterious effects of obesity that have nothing to do with feeling good about your body with physical appearance, right? It's also important to understand that racial minorities, again, data from the adult population, generally come into your clinics with a preconceived notion that surgery is a treatment of last resort and it's high risk. And we need to learn how to educate them on the fact that just the data doesn't show that. And instead of being a treatment of last resort, for children with severe obesity, it probably should be the first-line treatment, right? It's also important to address specifically the impact that implicit and explicit bias has on the provider side, both race-based and weight-based, for their likelihood of referring these children, and the impact that also current reimbursement models might have, both in their likelihood to refer the child of a certain race, ethnicity, or socioeconomic status for surgical evaluation, but also on the ability of that family to proceed with that referral. And it's crucial to note the impact that geographic distribution might have on both the likelihood to refer, and you saw some survey data before that pediatricians had that as a significant concern, but also on the ability of a family to comply with a preoperative and postoperative regimen plan if they live hours away from the nearest pediatric weight center. Now, this is data we tabulated and never published, but this is a map depicting the prevalence of obesity using the National Survey for Children's Health. And this is a map that shows the number of bariatric surgeons as listed in the ASMBS directory back in 2018 who indicated that they take pediatric patients. And you can see here as the numbers in most states are 1 or 2 or 3, and some states have 0. Now, one of the reasons we didn't publish this data is because we understand the ASMBS directory is not the end-all, be-all, and I'm sure many providers who do pediatric bariatric surgery are not listed there, but it does serve as a bit of a litmus test on some of the geographic barriers that these patients might experience, and that's a 30,000-foot view. That's not even zooming down to the state level and looking at those geographic differences there. So it's important to study that. First of all, we have no idea. We don't have great databases to study that other than MBSA QIP, and even that doesn't capture a lot of our pediatric population, and then address it, okay? There has been some work that has been done, by groups from Dr. Inge's group and nationwide and now in Chicago, and groups like Fatima Stanford up in Mass General, but a lot of work is left to be done. And I think the way to frame this question is in a health system of limited resources, if we are going to target the areas that are going to give us the most effective improvements in decreasing the disparity gap, we need to first of all figure out what the impact of all these different factors are along the entire journey from diagnosis to treatment, and then target those areas with our interventions. And it's going to take everyone's participation. So I'd like to leave you where I started. Remember, equity and equality are not the same, and keep in mind that social determinants of health are often underlying levers that are acting behind what your patient is already experiencing by the sheer color of their skin. Thank you very much.